Although the larynx is the source of the voice, phonation can be affected by disturbances in any body system. Despite the importance of vocal communication, it is only in the past 20 years that we have begun to understand the complexities of phonation. Voice is now a subspecialty of otolaryngology, and there is a new standard of care for all patients with voice complaints. Although the larynx is the source of the voice, phonation is affected by almost all body systems, something that should be kept in mind when evaluating a voice complaint. The larynx is essential to normal voice production, but the anatomy of the voice is not limited to the larynx. The vocal mechanism includes the abdominal and back musculature, the rib cage, the lungs, pharynx, oral cavity, and nose. Each component performs an important function in voice production, although it's possible to produce voice even without a larynx. For example, in patients who have undergone laryngectomy, removal of the larynx for cancer. In addition, virtually all parts of the body play some role in voice production and may be responsible for voice dysfunction. Even something as remote as a sprained ankle may alter posture, thereby impairing abdominal muscle function and resulting in vocal inefficiency, weakness, or hoarseness. The larynx is composed of 4 basic anatomic units: skeleton, mucosa, intrinsic, and extrinsic muscles. The most important parts of the laryngeal skeleton are the thyroid cartilage, cricoid cartilage, and 2 arytenoid cartilages. One of the intrinsic muscles, the vocalis muscle, part of the thyroarytenoid muscle, extends on each side from the arytenoid cartilage to the inside of the thyroid cartilage, just below and behind the Adam's apple, forming the body of the vocal folds, popularly called the vocal cords. The vocal folds act as the oscillator or voice source of the vocal tract. The space between the vocal folds is called the glottis and is used as an anatomic reference point. The intrinsic muscles alter the position, shape, and tension of the vocal folds, bringing them together, adduction, moving them apart, abduction, or stretching them by increasing longitudinal tension. They are able to do so because the laryngeal cartilages are connected by soft attachments that allow changes in their relative angles and distances, thereby permitting alteration in the shape and tension of the tissues suspended between them. The arytenoids are also capable of rocking, rotating, and gliding, which permits complex vocal fold motion and alteration in the shape of the vocal fold edge. All but one of the muscles on each side of the larynx are innervated by one of the two recurrent laryngeal nerves. Because this structure runs a long course from the neck down into the chest and then back up to the larynx, hence the name recurrent, it is easily injured by trauma, neck surgery, and chest surgery, which may result in vocal fold paralysis. The remaining muscle, cricothyroid muscle, is innervated by the superior laryngeal nerve on each side, which is especially susceptible to viral and traumatic injury. It produces increases in longitudinal tension important in volume projection and pitch control. The false vocal folds are located above the vocal folds. Unlike the true vocal folds, they do not make contact during normal speaking or singing. Because the attachments of the laryngeal cartilages are flexible, the positions of the cartilages change with respect to each other when the laryngeal skeleton is elevated or lowered. Such changes in vertical height are controlled by the extrinsic laryngeal muscles, or strap muscles of the neck. When the angles and distances between cartilages change because of this accordion effect, the resting length of the intrinsic muscles is also changed. Such large adjustments in intrinsic muscle condition interfere with fine control of smooth vocal quality. This is why classically trained singers are generally taught to use their extrinsic muscles to maintain the laryngeal skeleton at a relatively constant height regardless of pitch. That is, they learn to avoid the natural tendency of the larynx to rise with ascending pitch and fall with descending pitch, thereby enhancing unity of quality throughout the vocal range. Techniques may be different in certain Asian, Indian, Arabic, and other musical traditions with different aesthetic values. The soft tissues lining the larynx are much more complex than was originally thought. The mucosa forms the thin, lubricated surface of the vocal folds that makes contact when the two vocal folds are closed. It looks like the mucosa that lines the inside of the mouth. However, the vocal fold is not simply muscle covered with mucosa. Thin, lubricated squamous epithelium lines the surface. Immediately beneath it, connected by a complex basement membrane, is the superficial layer of the lamina propria, also known as Reinke's space, which consists of loose, fibrous components and matrix. It tends to accumulate fluid, and it contains very few fibroblasts, cells that cause scar formation. The epithelium is connected to the superficial layer of the lamina propria by a sophisticated basement membrane. The intermediate layer of the lamina propria contains primarily elastic fibers and a moderate number of fibroblasts. The deep layer of the lamina propria is rich in fibroblasts and consists primarily of collagenous fibers. It overlies the thyroarytenoid or vocalis muscle. The various layers have different mechanical properties important in allowing the smooth shearing action necessary for proper vocal fold vibration. Mechanically, the vocal fold structures act more like three layers consisting of the cover, epithelium, and superficial layer of the lamina propria, transition, intermediate and deep layers of the lamina propria, and body, the vocalis muscle. The supraglottic larynx, tongue, lips, palate, pharynx, nasal cavity, and possibly the sinuses shape the sound produced at the vocal folds by acting as a resonator. Minor alterations in the configuration of these structures may produce substantial changes in vocal quality. Obvious examples are the hypernasal speech associated with a cleft palate and the hyponasal speech characteristic of severe adenoid hypertrophy. Mild swelling from an upper respiratory tract infection, laryngeal scarring, and muscle tension produce less obvious sound alterations. Such alterations often elude the non-specialist. The lungs supply a stream of air that passes between the vocal folds and provides power for voice production. The diaphragm generates inspiratory force. The abdomen can perform this function in some situations, but is primarily a generator of expiratory force. Muscle cramps or impaired abdominal muscle tone can alter the voice. There are obvious changes in respiratory function with different postures, for example, standing or lying on the back. However, lesser changes, for instance, distributing the weight over the calcaneus rather than the metatarsal heads, also alter the configuration of the abdominal and back musculature sufficiently to influence the voice. Tensing the arm and shoulder muscles promotes cervical muscle strain, which can adversely affect the voice. Psychological factors affect the autonomic nervous system, which controls mucosal secretion and other functions critical to voice production. The nervous system is also important as a mediator of fine muscle control. This is worth noting, since minimal voice disturbances may occasionally be the first signs of a serious neurologic disease. Psychological factors may affect voice production in other ways, and may be the primary cause of voice impairment in some cases. The physiology of voice production is exceedingly complex, and other sources should be consulted for a more complete discussion. A simplified summary of the pathway of volitional phonation is shown here. Phonation requires interaction between a power source, the chest, abdomen, and back musculature, an oscillator, the vocal folds, and a resonator, the supraglottic vocal tract. The power generated by the chest, abdomen, and back musculature produces a high-pressure airstream. Rapid, complex adjustments of subglottic pressure occur during phonation, since the resistance varies almost continually as the glottis closes, opens, and changes shape. At the beginning of each phonatory cycle, the vocal folds are brought close to each other. Air pressure then blows them apart from the inferior portion upward, and from the posterior portion forward. They close in a similar fashion. Rather than vibrating like strings, the vocal folds emit pulses of air similar to those formed by buzzing lips on a trumpet mouthpiece. There is a vertical phase difference. The lower portion of the vocal folds begins to open and close before the upper portion. This rippling displacement of the cover layer of the vocal folds produces a mucosal wave that can be examined clinically under stroboscopic light. If this complex motion is impaired, hoarseness and other changes in vocal quality may result. The sound produced by the vocal folds is a complex tone containing a fundamental frequency and many overtones. It is substantially altered as it passes through the supraglottic vocal tract, whose components act as a series of interconnected variable resonators. Some frequencies are enhanced, others are attenuated. The supraglottic vocal tract is largely responsible for the distinctive sound or timbre of a person's voice. A comprehensive history often reveals the cause of hoarseness and other voice complaints. As noted previously, the contributions of all body systems must be taken into account. A questionnaire that incorporates the following details is often useful in eliciting information, ensuring that nothing is missed, and helping patients organize their thoughts. How old are you? As people age, all components of the vocal mechanism undergo natural, predictable changes. Muscle tone decreases in the abdomen and other areas. The lungs lose elasticity. The thorax loses distensibility. The mucosa thins, and muscles of the vocal tract atrophy. Mucus secretions change character. Nerve endings are reduced in number, and other biochemical, neurologic, and psychological changes occur. The laryngeal muscles lose tone and bulk as a person ages. By age 65, the laryngeal cartilages have ossified nearly completely, and like other synovial joints, the laryngeal joints may become arthritic. The hormonal environment changes. Vocal range, intensity, efficiency, and quality are altered. Voice problems often arise from unconscious attempts to maintain an accustomed pitch despite these changes. What is wrong with your voice? Patients often complain of hoarseness, although this term is used to describe a wide variety of symptoms. The coarse, scratchy sound of hoarseness is most often associated with abnormalities of the leading edge of the vocal folds, such as laryngitis or mass lesions. Breathiness is a vocal quality characterized by excessive loss of air during vocalization. Any condition that prevents full approximation of the vocal folds can be responsible. Such conditions include vocal fold paralysis, a mass lesion separating the leading edges of the vocal folds, arthritis of the cricoarytenoid joint, arytenoid dislocation, scarring of the vibratory margin, and senile vocal fold atrophy. Vocal fatigue of the voice is an inability to continue to phonate for extended periods without a change in vocal quality. The voice becomes hoarse, loses range, changes timbre, breaks into different registers, or exhibits other uncontrolled behavior. This may be a sign of generalized fatigue or of a serious illness such as myasthenia gravis. Each voice has its own dynamic range. Volume disturbance is an inability to phonate either loudly or softly. Most volume problems are secondary to intrinsic limitations of the voice or to technical errors in voice production, although hormonal changes, aging, and neurologic disease are sometimes involved. Superior laryngeal nerve paresis also impairs the ability to speak loudly. This is a frequently unrecognized consequence of viral infection, particularly with herpes, and may also be precipitated by an upper respiratory tract infection. A prolonged warm-up time before speaking, especially in the morning, is most often caused by reflux laryngitis. A tickling or choking sensation during speaking or singing is often a symptom of a problem on the leading edge of the vocal fold. Pain while vocalizing can indicate vocal fold lesions, laryngeal joint arthritis, infection, or gastric acid irritation of the arytenoids, but it is much more commonly caused by voice abuse from excessive muscular activity in the neck. How, when, and where do you use your voice? Although a detailed discussion of voice abuse is beyond the scope of this discussion, the physician should be aware of behaviors or environments often associated with abusive voice behavior and should ask about them routinely. For example, dry, dusty surroundings may alter vocal fold secretions through dehydration or contact irritation, affecting voice function. Yelling at children or during sporting events is among the most common harmful behaviors. Extensive use of the voice in noisy environments, such as restaurants, cars, airplanes, sport facilities, and other locations where background noise or acoustic design impair auditory feedback, also tends to be abusive. Activities such as cheerleading, teaching, choral conducting, amateur singing, and frequent conversation with hearing-impaired persons are associated with voice abuse, as is extensive professional use of the voice without formal training. The physician should also ask about specific activities that can lead to voice changes or discomfort in the throat, such as weightlifting, aerobics, and playing certain wind instruments. How is your physical condition? Phonation is athletic. It requires good conditioning and the coordination of numerous physical functions, particularly during such vocally demanding activities as public speaking, teaching, acting, and singing. When using the voice, a person will often compensate for physical weakness by using inappropriate muscle groups, particularly those in the neck, leading to vocal dysfunction. Similar problems may occur in the patient experiencing vocal fatigue. These problems can be compounded by mucosal changes that accompany overwork. Substantial fluctuations in weight frequently result in deleterious alterations of the voice. These voice changes usually are temporary. Debilitating conditions, such as mononucleosis or chronic anemia, may be noticed first as vocal fatigue. Do you have a cold or allergy symptoms? Acute upper respiratory tract infection causes inflammation of the mucosa, alters mucosal secretions, and makes the mucosa more vulnerable to injury. Coughing and throat clearing are particularly traumatic and may worsen or provoke hoarseness associated with a cold. Postnasal drip and allergy can produce the same response, as can the discharge and diffuse mucosal inflammation of infectious sinusitis. The latter may actually alter the patient's perception of the voice as well as its sound. Allergies are often problematic in voice patients because they alter laryngeal mucous membranes and lubrication. A history of allergy should be sought in patients complaining of intermittent hoarseness, breathiness, voice fatigue, or excessive phlegm and throat clearing. It should be remembered that laryngopharyngeal reflux can also cause these symptoms, so it should not be assumed that the presence of these symptoms is sufficient to establish allergy as the cause. Do you have dental or temporomandibular joint problems? Particularly in temporomandibular joint, TMJ dysfunction, but also in dental disease, increased muscle tension is transmitted from the head and neck to the larynx, both directly through the muscular attachments between them and the hyoid bone, and indirectly in the form of generalized tension. The result is often decreased vocal range, vocal fatigue, and changes in the quality of the voice. Do you have morning hoarseness, bad breath, excess phlegm, or heartburn? Reflux laryngitis, chronic irritation of the arytenoid cartilages, and vocal folds from the reflux or gastric juice is seen in many patients with voice complaints. Dyspepsia may occur in association with this condition, but the key features are a bitter taste and halitosis on awakening, a dry or coated mouth, a scratchy sore throat or lump in the throat, hoarseness, and a need for prolonged vocal warm-up. The physician should ask about these symptoms routinely since a patient who has had the problem for many years may not realize it is abnormal. Do you or any of your blood relatives have hearing loss? Hearing loss is often overlooked as a source of voice abuse or overuse. Speaking loudly to a family member who is hard of hearing can produce significant chronic vocal strain. Auditory feedback is fundamental to vocal control, and interference with this mechanism may result in altered voice production, particularly when the speaker is unaware of having hearing loss. Do you have trouble with your belly or bowels? Any condition that alters abdominal function interferes with the power source of the voice and may result in a voice complaint. Examples of such conditions include muscle cramping, constipation, diarrhea, and even anxiety, among others. Do you have difficulty breathing, especially after exercising? Because they affect the power source, respiratory problems play a significant part in disorders of the voice. Even mild respiratory dysfunction may have an adverse effect on the power supply of the voice. Occult asthma may be particularly troublesome. A complete respiratory history should be obtained in patients with voice complaints, and pulmonary function testing is often advisable. Are you under particular psychological stress or in therapy? Psychological phenomena may be responsible for a variety of voice aberrations. These may present as hoarseness, aphonia, a whispered voice, or even vocal nodules resulting from stressful phonation. Such problems require expert diagnosis and treatment, and are often somewhat easier to manage in patients who do not depend on their voice for a living. Have you been having troubles with weight gain, fatigue, cold sensitivity, or menstrual irregularity? The voice is highly responsive to hormonal changes, many of which produce alterations in the fluid content of the lamina propria, located directly beneath the laryngeal mucosa. This in turn causes alterations in the bulk and shape of the vocal folds, with resultant voice change. Unexplained weight gain, fatigue, cold sensitivity, and/or menstrual irregularity can suggest hypothyroidism as well-recognized causes of voice disorders. Even mild hypothyroidism may produce hoarseness, vocal fatigue, muffling of the voice, loss of range, or a sensation of lump in the throat. This diagnosis should be considered even when the results of thyroid function testing are within the low to normal range, and especially when thyroid stimulation hormone, TSH, levels are in the high normal range or are elevated. Thyrotoxicosis may result in similar voice disturbances. Have you recently begun menopause, had cyclical voice changes with menses, or had other hormone-related problems? Voice changes associated with fluctuations in sex hormone production are seen commonly in clinical practice, usually in women. Although vocal changes associated with the normal menstrual cycle may be difficult to quantify, there is no doubt they occur. They are seen mainly in the immediate premenstrual period, when they are known as laryngopathia premenstrualis. This common condition is believed to be caused by anatomic, physiologic, or psychological alterations secondary to endocrine changes. The vocal dysfunction is characterized by decreased vocal efficiency, loss of the highest notes in the singing voice, vocal fatigue, slight hoarseness, and some muffling of the voice. Submucosal hemorrhages in the larynx are common. Ovulation inhibitors have been shown to mitigate some of these symptoms. However, oral contraceptives may deleteriously alter voice range and character in about 5% of all women using them, even after only a few months of therapy, and the voice should be monitored closely when these agents are used. Estrogens used under the supervision of a gynecologist or endocrinologist are helpful in maintaining vocal quality following menopause. Female voice professionals who develop endometriosis should not be treated with androgens, even at low dosages, when there is any reasonable alternative, since these substances can cause irreversible vocal unsteadiness, rapid changes in timbre, and lowering of the fundamental voice frequency. Vocal dysfunction can be caused by hormonal disturbances in other segments of the diencephalic pituitary system, including the parathyroid, adrenal, pineal, and pituitary glands. Other endocrine disturbances can also alter the voice. For example, pancreatic dysfunction, as in diabetes mellitus, can lead to xerostomia, dry voice, and thymic abnormalities can lead to feminization of the voice. Have you been exposed to environmental irritants? Allergies to dust and mold are common causes of voice problems, but any mucosal irritant can disrupt the vocal mechanism. Generalized mucosal irritation is suggested when nasal obstruction and erythematous conjunctivae are present. Cold air and dry heat may have a drying effect on mucosal secretions, leading to decreased laryngeal lubrication and a scratchy voice and tickling cough. Patients can minimize these symptoms by breathing through their nose, which allows inspired air to be filtered, warmed, and humidified. A history of recent travel may suggest other sources of direct mucosal irritation. Not only is the atmosphere in airplanes extremely dry, but noise in the cabin may force travelers to speak loudly. Patients should be advised to speak at a normal volume and maintain nasal breathing and good hydration during air travel. Changes in air quality and humidity with environmental or geographic changes can also be disruptive. Do you smoke, work around smokers, or live with a smoker? Tobacco smoke's deleterious effects on the mucosa are indisputable. It causes erythema, mild edema, and generalized inflammation throughout the vocal tract. The head of the burning cigarette also appears to be involved. The smoke of marijuana, which is unfiltered and inhaled deeply, is particularly irritating and produces a considerable mucosal response. What medications and substances do you use? If the patient is currently taking antibiotics, it's important to find out the dose, the prescribing physician, and whether the patient frequently self-treats with inadequate courses of antibiotics. Treatment with inappropriate or inadequate courses of antibiotics may lead to prolonged laryngitis and more serious vocal fold injury. This scenario is especially common in patients who treat themselves with borrowed antibiotics or with antibiotics left over from a previous prescription that was not completed. Diuretics are popular drugs, often prescribed by gynecologists at the patient's request to help reverse premenstrual fluid retention. Unsupervised use of these drugs may result in dehydration and consequent laryngeal mucosal dryness. Hormone use, especially oral contraceptives, must be elicited specifically, since patients often forget to mention them. Vitamins are also frequently forgotten. Most vitamin therapy seems to have little effect on the voice, but the high doses of vitamin C, 5 to 6 grams per day, that some people take to prevent colds, seem to act as a mild diuretic and may lead to dehydration and xerostomia. Although many patients take antihistamines for postnasal drip and other symptoms, these agents should be used with caution. Their drying effect may result in decreased vocal fold lubrication, increased throat clearing, and frequent coughing. A history of alcohol abuse suggests a likelihood of poor vocal technique. The lack of coordination and decreased awareness that accompany intoxication undermine normal vocal mechanisms. The effect of small amounts of alcohol is controversial. Cocaine use can be extremely irritating to the nasal mucosa, causes marked vasoconstriction, and may alter the sensorium, resulting in decreased voice control and a tendency toward vocal abuse. Are there foods that seem to affect your voice? Various foods are said to affect the voice. Traditionally avoided by singers before performances, milk and ice cream are associated with increases in the amount and viscosity of mucosal secretions. Chocolate may have similar effects. Casein allergy has been hypothesized, but no satisfactory mechanism has yet been established. Restricting intake of these foods before voice commitments may be helpful. Coffee and other caffeine-containing beverages aggravate gastric reflux and seem to alter mucosal secretions, necessitating frequent throat clearing in some people. Large quantities of these beverages may also cause hyperactivity and tremor. On the other hand, lemon juice and herbal teas are both felt to be beneficial to the voice, possibly acting as demulcents, thinning mucosal secretions. When inquiring about foods, it's helpful to determine whether the patient eats immediately before voice use. A full stomach can interfere with abdominal support, and contraction of the abdominal muscles can result in a reflux of gastric juice. Eating habits are also important. Fad diets, especially rapid weight loss diets, are notorious for causing voice problems. Have you recently experienced weakness, tremor, fatigue, or loss of control of your voice or body? Even minor neurologic disorders may be extremely disruptive of vocal function. It's important to rule out neuromuscular and neurologic diseases that may present as voice problems, such as myasthenia gravis, Parkinson's disease, dystonias, for instance spasmodic dysphonia, multiple sclerosis, and central nervous system neoplasm. Have you been injured? The potential for dysphonia to be caused by neck or distant injury should not be underestimated. For example, whiplash often results in spasm of the neck muscles and abnormal neck posturing secondary to pain, with consequent hyperfunctional voice technique. Voice problems also have been observed after trauma to the head, supraglottic region, chest, abdomen, and upper and lower extremities. Did you have surgery before your voice problems began? A history of laryngeal surgery immediately before the development of the current voice complaint should raise a suspicion of significant trauma. It's necessary to establish exactly why and by whom the surgery was done, whether intubation was necessary, and if the surgery was for nodules associated with voice abuse, whether voice therapy was instituted before surgery. There may be trauma related to the surgery, the intubation, or both. Removal of the tonsils can alter the voice by changing the configuration of the supraglottic vocal tract. In addition, scarring may alter pharyngeal muscle function. It generally takes from 3 to 6 months for the voice to stabilize or return to normal following tonsillectomy. Neck surgery, such as thyroidectomy, may result in scarring of the extrinsic laryngeal musculature that leads to permanent impairment of the vocal mechanism. An injury to the recurrent or superior laryngeal nerve during neck surgery may explain a hoarse, breathy, or weak voice. In rare cases, patients can compensate for recurrent laryngeal nerve paralysis and have a nearly normal voice. Thoracic and abdominal surgery interfere with respiratory and abdominal support. After these procedures, therefore, extensive use of the voice should be prohibited until pain has subsided and there has been sufficient healing to allow normal support. It is often advisable for the patient to be able to do abdominal exercises before resuming vocalizing. Other surgical procedures may be significant if they necessitated intubation or affected the musculoskeletal system in a way that requires changes in stance or balance. For example, balancing on one foot after leg surgery may decrease the effectiveness of the support mechanisms and produce vocal strain, fatigue, and hoarseness. A detailed history of the type just described frequently reveals the cause of the patient's voice problem even before the physical examination is performed. However, a comprehensive physical examination, often including objective assessment of vocal function, is also essential. When assessing the patient's general physical condition, the physician should keep in mind that a disturbance of almost any body system can result in voice dysfunction. A patient who is extremely obese or who appears fatigued, agitated, emotionally stressed, or otherwise generally ill demonstrates a potential for voice dysfunction resulting from various alterations in, for example, abdominal support, fine motor control of the laryngeal muscles, bulk of the submucosal vocal fold ground substance, and character of the mucosal secretions. Any physical condition impairing normal function of the abdominal musculature can cause dysphonia. Pregnancy is an obvious example, but a sprained ankle or broken leg that requires the patient to adapt an unaccustomed stance can also affect abdominal support and result in voice dysfunction. The physical examination of a patient with a voice problem should include a thorough ear, nose, and throat evaluation. The ear examination should include an assessment of hearing acuity, since even a relatively slight hearing loss may result in voice strain. The effect is most pronounced in sensorineural hearing loss. With conductive hearing loss, patients tend to use their voice more softly than is appropriate rather than too loudly, which is less harmful. The conjunctivae and sclerae should routinely be observed for erythema, suggesting allergy or irritation, for pallor, suggesting anemia and its associated fatigue, and for abnormalities such as the yellow sclerae of jaundice, with its associated fatigue and multisystem effects. This may reveal the problem that is affecting the vocal tract even before the larynx is visualized. Examination of the nose should include patency of the airway, character of the nasal mucosa, and nature of the secretions. Anatomic obstruction may make it impossible to breathe through the nose, forcing the patient to breathe unfiltered, unhumidified air through the mouth. The presence of pale, gray, allergic mucosa or swollen, infected mucosa in the nose suggests abnormal mucosa elsewhere in the respiratory tract. Examination of the oral cavity should pay careful attention to the tonsils and lymphoid tissue in the posterior pharyngeal wall and tongue, as well as to the mucosa. Diffuse lymphoid hypertrophy associated with a scratchy voice and irritative cough may indicate chronic infection. The amount and viscosity of mucosal and salivary secretion should be noted. Xerostomia dry mouth is particularly significant. Dental examination should focus not only on oral hygiene, but also on the presence of wear facets, suggesting bruxism, tooth grinding. The latter is a sign of excessive muscular tension and may be associated with TMJ dysfunction, which should also be looked for routinely. Thinning of the enamel of the central incisors in a patient of normal or less than normal weight may be a sign of bulimia, but may also be from excessive sucking on lemons or limes. The former can cause voice problems similar to those of reflux, whereas the latter causes no voice problems unless it aggravates pre-existing reflux. The neck should be examined for masses, restriction of movement, excessive muscle tension, and scars from previous neck surgery or trauma. Range of motion and the posterior neck muscle should not be neglected, and particular attention should be paid to the thyroid gland. Laryngeal vertical mobility is also significant. For example, a partial fixation of cervical muscles cut during surgery may tilt the larynx and produce voice dysfunction, as may fixation of the trachea to overlying neck skin. The cranial nerves should also be examined. Diminished facial sensation, diminished gag reflex, palatal deviation, and other multiple cranial nerve deficits may indicate mild cranial polyneuropathy. Post-viral neuropathies may involve the superior laryngeal nerve and cause vocal weakness, fatigability, and loss of range. More serious neurologic disease may also be associated with such symptoms and signs. Examination of the larynx has certain unique aspects. It begins when the patient enters the physician's office, at which time the range, ease, volume, and quality of the speaking voice are noted. Excessive volume or obvious strain during speaking is a clear indication of voice abuse that may be contributing to the patient's problem. Any patient with a voice complaint should undergo at least indirect mirror laryngoscopy. It is not possible to assess voice range, quality, or other vocal attributes by inspection of the vocal folds, but it is necessary to establish the presence or absence of vocal fold masses, vocal fold mobility, immobility, erythema, and edema of the arytenoid cartilages and vocal folds, and other anatomic abnormalities. Direct laryngoscopy, including stroboscopic examination, should be performed by an otolaryngologist. This allows diagnosis of abnormalities of the vibratory margin of the vocal fold. For example, masses, scars, cancers, subtle signs of paresis that cannot be visualized without stroboscopy. This examination should be performed when the diagnosis is in doubt or when symptoms do not respond promptly to treatment. In many cases, objective voice assessment is necessary before the diagnosis can be established or treatment initiated. This is not usually necessary in patients with acute laryngitis or another obvious problem that resolves quickly, but should be performed in patients with dysphonia of an uncertain cause, dysphonia that lasts more than a few weeks, or lesions such as vocal nodules that require voice therapy. Objective voice assessment generally includes strobo-video-laryngoscopy, electroglottography, evaluation of phonatory and respiratory function, acoustic analysis, formal assessment by a speech-language pathologist, and occasionally laryngeal electromyography. More information about objective analysis of the voice can be found in the literature.